Good morning, everybody. Welcome to our Coffee and Connections event. And people that are just now joining us, give you a chance to log in and unmute yourself. We'll be starting in just a few moments. Make sure you've got your coffee, your tea, whatever you prefer to drink in the morning. And we shall begin shortly. Morning, Hector.
Good morning.
We'll be starting in just a moment. We've got our early morning meeting. I see a few familiar faces. Mark, good morning.
Good morning, George. How are you?
I'm well, thanks.
Good.
Got my coffee going, and I think I'm ready to rock and roll this morning. Okay, we'll give it just another minute. What I'd like to do is in the chat feature, if everybody could put their name and the organization that you're with, that would be much appreciated. We're going to keep the chat feature, and we're also going to hopefully keep this conversational today. Good morning, Cherry.
Good morning.
Yes, Ebenezer.
Okay. All right, great. Okay, we're going to start in just a moment. We are getting a few more people in at this point. As I had mentioned, we're going to be starting in just a moment. A couple notes. Grab your smartphones. We're going to be doing a Mentimeter to kick this off. If you're not familiar with Mentimeter, on your web browser, on your smartphone, go to Mentimeter, mentimeter.com, mentimeter.com, and I'll show you what to do in just a moment. But we're going to be starting off with a little Mentimeter poll. It's a different way to get some input from the people that are here. It looks like it is 7:05, so we're going to go ahead and get rolling. Welcome, everybody, to Coffee and Connections, 7 o'clock on Friday. I am really Glad to be here. Glad that everybody is here. My name is George Yogtik. I'm the Training and Engagement Facilitator at the California Health Collaborative. I'd like to start off with a couple notes. Here's some housekeeping items. This session is being recorded. And Cameron, I'd like to say, if you want to go ahead and start recording now, that would be great. If you have any problems about being recorded, please keep your screen off. Otherwise, we encourage you to keep your screen on, because we will be having some questions that will come up and arise during the course of this event. Always good to see faces, always nice to see familiar faces. If you're attending remotely, please make sure your Zoom microphone is on mute. If you have audio issues, joined by phone, make sure your name is typed in so that we can input it appropriately in our raffle prize drawing. We're going to be having a raffle prize at the end of this event today. And lastly, check your pronouns. Mine are he, him, and his. If you want to add that to your name, you're more than welcome. As it goes to introductions, ACEs Aware, the King's Collaboration, which has just recently changed its name to a Network of Care, with funding from ACEs Aware, is a collaboration of California Health Collaborative, the Kings County Department of Public Health, the King's Partnership for Prevention, and Kings United Way. All of us here, we very much appreciate the work that our partners who have committed to moving this work forward and to improving the health and well-being of individuals, families, and the communities in which we live. I'd like to take this moment to do a couple introductions. As I had said before, my name is George Yogtik, pronouns he, him, and his. I'm the Training and Engagement Facilitator here at the California Collaborative. Proud to be a part of the ACEs Aware initiative, which trains providers to better define adverse childhood experiences, their prevalence, and their impact on health, including underlying biological mechanisms. I have a clinical background in creative arts therapy and have worked in both outpatient and inpatient acute care. My experience have a strong foundation in patient-centered care and is resiliency-based. I feel strongly about this work and current changes that are taking place in the field. I'm excited about being here today to bring you this information. To continue this round of introductions, I'd like to start with our collaborators. I'm going to go ahead and pass this on to Cameron. If you could just unmute yourself and give a brief introduction. We're going to go around our collaborators first, the people who have helped to make this event happen, and then we're going to go around the room and have people introduce themselves individually. Cameron, you want to start us off?
Perfect. Thank you, George. Good morning, everyone. My name is Cameron Jones, and I work with KPFP as the Communications Coordinator.
Erica?
Thank you, George. Good morning, everybody. My name is Erica Lopez, and I am the 211 Coordinator at Kings United Way.
And Lexi?
Good morning, everyone. My name is Lexi Turrell. I'm the Community Engagement Manager with Kings United Way.
Excellent. Thank you all. The three that you just saw here are part of our collaboration. Very happy to be here with you. Now I'd like to ask you all to unmute yourself. I'll go ahead and call out your names and to help expedite the process, and introduce yourself and the organization that you're with. Mark, would you like to start us off?
Thank you, George. I'm Mark Tebow. I'm with the First 5 Kern ACEs Aware Network of Care grant team. I'm the co-lead.
Thank you, Mark. Hector?
Morning, everyone. Hector Gutierrez, Strategic Initiative Specialist with First 5 Kern. I also serve as a co-lead for the ACEs Aware Planning Grant that we received through the state. Happy to be here today.
Excellent. Thank you, Hector. Let's go with Mallory Berrigan.
Hello, my name is actually Sophia Orgel. I'm the health educator at Family Healthcare Network in Hanford, California. I don't know why I'm showing Mallory though.
If you could rename your name, just that, Cameron, that's just a note. Mallory is Sophia. Want to make sure that we get it right for not only our recording purposes, but for our raffle prize at the end. We want to make sure the appropriate person, if your name is called, that you win. If you're familiar with how to rename it, you go up to the 3 dots on the side of your name and it should have a rename option, just to let you know. Let's keep the introductions going. Liz, would you like to introduce yourself?
Good morning. My name is Liz Paul. I am joining you from Boise, Idaho. I am the coordinator of a funded learning collaborative, patient-centered learning collaborative on ACEs screening, and we're working with the Idaho Children's Trust Fund and the Idaho Head Start Association, which is where I have been working for a few years doing advocacy. And our learning collaborative is we're doing focus groups with patients, also known as parents. This is about 4-month well baby screening appointments and having doctors talk to the parents about their childhood experiences at that point. So this is about healthy families and strengthening families. And I was told about this, and I'm happy to be here today.
That's great. Thank you, Liz.
Mhm.
All right. So Yvette Oliveira.
Good morning, this is Yvette Oliveira. I'm the 211 database specialist with Kings United Way.
Thank you. Anastasia.
Good morning, everyone. My name is Anastasia Lester. As you can see, it's early for us. I am a program officer at First 5 Kern, and I'm excited to be here. Thank you.
That's great. We've got a lot of Kern County here. Very much appreciated. Cherry, would you like to introduce yourself?
Yes, good morning, everyone. I'm Cherry Price. I'm an educator in Maryland. I've been an educator for about 25 years. And the year that we were in lockdown, I learned a lot about ACEs, and I'm very impressed with the work that California is doing. So I attend a lot of these trainings because I'm trying to work with my school system to move us to a trauma-informed model of care. And so I'm here to listen and learn.
Excellent. Thank you, Cherry. We have 2 more. I see Metaxia. I hope I'm saying that right. I see Metaxia. Would you like to unmute yourself and introduce yourself? And going once, going twice. All right. Continuing, moving on. We have a phone caller with the last 4 digits, 7936. Phone caller, would you like to unmute yourself and introduce yourself?
Good morning, everyone. My name is Master Sergeant Diana Garcia. I am a preventionist with the California National Guard Counter Drug Task Force. I am also with the Central Valley HIDA, which is High Intensity Drug Trafficking Area, and I am the Prevention Initiative Commander there. Glad to be here. Have fun.
Thank you, Diana. And for Cameron, the phone caller was Diana. I'm sorry, Diana, what was your last name again?
Galpin, Galpin, formerly Garcia.
Diana Galpin. Yes, we do have. You've been to our events before. It's good to have you back. Thank you. And I think, there we go. Sophia's got her name up there. Excellent. Congratulations on changing your name around. All right, let's talk a little bit about our agenda. We have a Mentimeter poll, which we're going to try next. We're going to go into and talk a little bit about ACE screenings, when, where, and how the best way to screen with conjunction with the algorithm. And we're going to look at the PDSA, or the Plan, Do, Screen, Act cycle of how to improve our referral process. At the end of the event, we are going to have a short presentation by 211 and the referral exchange. Questions will be answered, and hopefully a discussion type of an atmosphere will be promoted throughout this entire presentation. And we're going to end at 8:10. Okay, on that note, go ahead and pull out your smartphones and enter the code 4856-2599. So smartphones 4856-2599. That's mentimeter.com and menti.com, www.menti.com, and use the code 4856-2599. The first question, our test question, let's just see how many people we've got on their phone. Have you taken the ACEs provider core training? This is a way for us to get a count of how many people are using Menti Let's see, we've got 2 that haven't and 5 that have. That's excellent. I'm going to use that as our 7 count for the people that are using Mentimeter. I'm glad to see that a majority have taken the core training. We're not necessarily going to be talking much about the core training. Oh, great, there's 6 that have taken it. Glad to see everybody's jumping in on Mentimeter. We strongly encourage people, if you have not taken the core training, to do so. It works in conjunction with our supplemental trainings. Okay. 6, 7, 8. Our next question. Do you utilize the ACE screening tool? Do you personally utilize the ACE screening tool with patients, with clients, with, what are some other words that people use with utilizers?
Members.
Or members, there you go. Thank you. Thank you, Mark. Great. I appreciate you jumping in there. Do you utilize the ACE screening tool? Voting is closed. Open voting. There we go. Let's try that again. Go ahead. Do you utilize the ACE screening tool? 7 and 8. So most people here don't. Okay. For the one person who does use the screening tool, can you just tell us who you are so I can get a person behind that who uses the screening tool?
It's me, Sophia. I believe our company just started it. I'm kind of new to this, so I have seen the tool being used.
Okay, excellent, great. So most people here currently do not actually utilize the tool. That'll help us as we move forward. Do you use the algorithm? This is the algorithm. We will be talking about the algorithm today. It goes along in conjunction with the tool. There are 3 parts to that algorithm. There is the screening tool score itself. There is the adverse health condition. And there is the referral process at the end, right? So most people have not. We'll talk about the algorithm. I actually really like the algorithm because it puts into perspective how this all comes together and how it works with toxic stress. Last one, are you connected with a network for referrals? And this is where we're really looking at improving today, is our network for referrals. And I'm going to assume that we're going to have more yeses this time than nos. Are you connected to a network for referrals? Yes, 5, 7, 5, 7, 8, 9. There we go. There's our 9. Most people have, and 1 somewhat. Great. Excellent. And that is Mentimeter, folks. I'm going to go ahead and close the voting on that. It's good to see. Just take a second to move my notes over. Helps us get a take on who is here. All right, so let's dive into it. We've got a lot of material to cover today. Since most people aren't using the screening tool, I might jump over a couple items. What I'd like you to do is, if you have questions, if you have comments, if you have anything that pops up during the course of this presentation, I'd like you just to jump in there, just like Mark did. Unmute yourself and say, hey, George, how does this work? Hey, George, I'm curious about this component of it. This presentation is primarily focused on providers, people who use the tool, and some of those details about the tool itself. So we're going to really get into the nitty-gritty of how that works. In California, more than 6 out of 10 of us have experienced at least one adverse childhood experience, an ACE, such as having a caregiver with mental illness or witnessed domestic violence. 1 in 6 of us have experienced 4 or more ACEs. The good news is that ACEs are not destiny. Every day we're learning more about how to effectively interrupt the progression from early adversity to disease and early death. These lessons are being applied to policy and practice in our clinics, in our hospitals, our schools, our workplaces, childcare centers, courtrooms, and elsewhere throughout our communities. What fuels my optimism here is the broad range of already being taken by passionate healthcare officials, advocates, educators, and others to advance innovative solutions. We have an army of people who have rolled up their sleeves and are willing to, and ready or already hard at work on these issues. The work could not be more timely. Today, in the midst of global pandemic, record-setting wildfires, and historic civil unrest, many communities across California are experiencing adversities than ever before. The extraordinary disruptions and hardships brought on by these circumstances have impacted everyone, but particularly our most vulnerable neighbors. There's never been a more urgent time for this work. The negative consequences of ACEs can be averted by preventing additional exposures in children, providing buffering interventions for both children and adults as soon as exposure to ACEs and risk for toxic stress is identified. But ideally, before the development of significant toxic stress physiology or clinical apparent disease. However, it's important to screen for ACEs and provide buffering care as early as possible because adversity can become biologically embedded as early as the prenatal period. The signs of toxic stress can manifest as early as infancy. Studies reveal the resiliency of the human brain and how communities working together can help buffer the toxic stress response. ACEs are only one part of a person's story. Knowing one's ACE score and how it may have contributed to their overall health and wellness can be important, but remember that trauma can be overcome. Our bodies, by their very nature, want to heal. With early detection and evidence-based intervention, we can transform health outcomes. How do we do that? As science illuminates the extent to which our experiences and environments shape our biology, there is increased recognition that clinical interventions are necessary, but not sufficient. To reduce the health impacts of ACEs and toxic stress, cross-sector coordination, including from within healthcare, is necessary. In the healthcare setting, providers can emphasize the following in patient education, anticipatory guidance, and linkages or referrals to resources. Economic supports, such as links to special supplemental nutritional programs for women, infants, and children, and tax credit programs. Parenting and family relationship skill building, promoting healthy relationship norms. Optimizing social, emotional, and other learning at home, such as there's a program called Talk, Read, Sing, and another one called Reach Out and Read programs. Connecting youth to caring adults, there's your buffering relationships and activities. High quality, affordable home visitation and childcare. Preschool and school enrichment with family engagement, and legal supports, such as through medical legal partnerships like the Developmental Understanding and Legal Collaboration for Everybody, which is an acronym DULCE. Coordination with other sectors such as schools, childcare, justice, social service, and public health can be done sustainably when providers leverage team-based approaches to clinical care. Models of care that integrate primary care and behavioral health in one setting help both patients and providers by blending the expertise of mental health or behavioral health clinicians and primary care clinics. These models have been effective, especially when they incorporate feedback from patients and/or their caregivers. Now, if you're familiar with a treatment team setting or a treatment plan, there's also something called a health worker model, and this health worker model really helps us establish that connection between the patient, of course, their ACE score, and the referral. And we'll be talking a little bit about the healthcare model in just a moment. But it's part of a treatment team setting, having somebody like a health worker who can actually help facilitate the movement along that referral process, help the patient. So what are some examples that clinicians can do to prevent ACEs and toxic stress? All right, a couple examples here. Clinicians on the healthcare team can refer families who are at risk for ACEs and toxic stress to home visiting programs like the Nurse Family Partnership Program. NFP has resulted in a 48% reduction in child abuse and neglect, improved cognitive and language development, gains in academic achievement, lower rates of substance use, fewer behavioral problems, and fewer arrests, convictions, and parole violations by age 19 for participating children. Social service or behavioral health clinicians on the primary care team can engage with child welfare agencies to ensure that referrals not only address child safety, but also attend to root causes of adversity through services such as stress management, parenting support, and assistance with financial, housing, and food security, depending upon the family needs. One valuable resource, if you're not familiar with it, is called Help Me Grow. It's available in many locations to connect service providers to each other to create an interconnected system of care to meet individual family needs. There's a number of other service providers here in the county, including Aunt Bertha, 211, and the referral exchange, which we're going to be talking about later on in the presentation. Clinicians can also encourage connection with caring adults, and this is really the most important, is those nurturing and sustaining relationships. Teachers, coaches, mentors, they can support engagement in protective activities like sports, arts, and music programs during or after school hours. These connections can reduce absenteeism, prevent substance use, and improve parent-child and student-teacher relationships. Nurturing relationships are really the key in keeping sustaining the recovery process and helping us stay strong in these aspects. Finally, California is leading the way in improving the lives of our most vulnerable residents by investing in a cross-sector framework for preventing, screening for, and treating ACEs and toxic stress. Preventing and addressing ACEs and toxic stress are key components for our overarching efforts to advance equity, improve health and well-being, reduce homelessness and other adversities, and moving towards person-centered value-based care. If you're familiar with person-centered care in terms of the treatment team, it's a perspective that that has been rolled out since the mid-2000s. And really looks at the patient being the center of the treatment team, and that patient driving the boat, as it were, in their treatment. So in terms of examples of cross-sector network of care, I'm wondering if anybody here has encountered, go ahead, unmute yourself and give us an example of working with a primary care provider or with somebody who has utilized your organization and the services it provides as a referral. Is there anyone here who has actually been an integral part of the referral process?
George,
I
I can talk a
haven't,
little. Go for it, Sophia.
sorry, I haven't been actually in the process yet, but because I work here at Family Healthcare Network in Hanford, I do see a lot of our providers, and they're the ones who do most of the referrals. Metaxa Banning is actually the physician assistant here. She's just having some issues with her unmuting, and she would probably be able to be the one to answer a little bit more about that. But I'm kind of new to this, so I believe I'm going to be a part of the referral process as well now.
That's great. That's wonderful. And I'm glad to see that Family Healthcare Network is represented today, both Metaxia and Sophia, because Family Healthcare Network has a protocol in place about referrals. And we're going to actually be talking about that today. So you'll have something that is right there and as part of your process already. Hector, did you want to share a little bit?
Yeah, so as part of our ACEs Aware planning grant, one of our clinical providers from Omni Family Health has been working with our local Unite Us partner kind of network referral. It's called Kern Connected Community Network. It's funded through the Kern Community Foundation, Unite Us, and a bunch of other funders to kind of build this local network of organizations that can connect, communities to a closed loop referral network within the Unite Us platform. Dr. Rao, who is our clinical partner, has started piloting, the screening in her clinic, and has been using the referral to make referrals to her medically complex children and families that she's engaging. What she's found is the kind of services that they're looking for is access to childcare because they're high need children, resources around food insecurity, and then resources to address economic security and job access within the local community.
Thank you, Hector. I appreciate that. I think it's getting connected to the referral process is incredibly important, either building yourself as part of the network of care or being a part of the primary care process itself. And our network of care meeting is coming up on Monday. That is Monday at 2 o'clock, 2 to 3:30. And it's really a chance to get to know other network members and get to know who's out there to support that ongoing referral process that you're talking about. Let's dive a little bit into the details of the screening process itself. Many experts in the field agree that screening for adverse childhood experiences and trauma is an integral component of trauma-informed care. There are varying opinions, however, on when and how to screen in adults and children, and what to do with the information obtained when screening. So all of this is sometimes overwhelming to providers who already have 100 things to do and tasks at hand. So there's a number of considerations that providers should acknowledge prior to screening for ACEs and trauma. While the best practices relate to screening in ACEs and trauma are still evolving, many providers agree on the following 4 points with regard to the screening. Treatment setting and patient population should guide the screening. So that means upfront universal screening may be more appropriate in primary care settings, particularly among working with pediatric populations. But other providers, such as behavioral health clinicians, many may prefer to screen for ACEs after a patient and provider have an established relationship. Variation in the frequency and type of screening tool used might also exist between treatment settings and between those with adult and pediatric populations. So what we're looking at is having the patient, this is patient-centered care, having the patient guide the screening tool itself. When does that screening take place? And do you provide a de-identified or an identified screening tool? If you're not familiar with those two things, the identified screening tool actually lists the ACE score next to the question so that they will check off which ACE, which adverse childhood experience they have encountered. The de-identified does not list those responses next to the question. It just gives a total at the end of the box. Now, many people feel that the de-identified screening tool is better for people because it helps prevent re-traumatization. Parents feel a little bit safer. They don't have to identify which adverse childhood experience they or their child has encountered. So de-identified and identified screening tools, make sure you hold on to that point of fact, because it can really help people, help providers feel a little bit more comfortable about giving a screening tool. And the screening tool itself, it should benefit the patient. Number 2, providers screening for trauma must have a clear strategy in place for utilizing the information in a way that supports patients' health, including a treatment plan connected to an established referral network. And that's really what we're talking about here. What do we do after the screening score? We actually take the score, look at any adverse health conditions that may be present, and provide education and a referral. And the real key to that educational process and the referral process is referring to things that reduce toxic stress and referring to things that help with social supports. Now, there's care coordination. And this is where we're talking about the community health workers. They should be employed to avoid rescreening. Sharing results across treatment settings with appropriate privacy protections may help reduce rescreening and the potential for re-traumatization, which is what we want to avoid. However, in pediatric populations, screening for exposure to ACEs is often conducted periodically, since our exposure may occur after initial screening and throughout childhood and adolescence. Now, in terms of how often we screen, up until age 18, it's recommended you screen once a year. And this is because, as I have just mentioned, these traumatic experiences may come up the year after, let's say the first screening is. So you need to, in early development, screen annually. After age 18, you only really need to screen once when you have a new patient come in. And again, you want to think about re-traumatization because the screening tool process itself can be and can elicit a high stress response to actually doing the screening, thinking about those traumatic events that have come up. Lastly, ample training should precede screening. And this is where the core training comes in, or our supplemental trainings come in. Healthcare professionals should be proficient in trauma screening and conduct patient follow-up in a manner that is sensitive to cultural and ethnic characteristics. ACE assessment tools are available in both identified and de-identified formats, which I mentioned before. The providers can choose the one that works best for them, and decide which is easier to implement. There's also the Pearls tool, which is the tool used for children and adolescents. So there's different tools that are specifically created for different people at different times. Any thoughts or questions about those 4 tenets? About what we just went over in terms of the screening tool itself? Again, if you really hold in your mind an understanding of patient-centered care, of trauma-informed care as you move forward with the screening tool, those two perspectives are really going to help you, letting the patient drive the process and understanding that we don't want to re-traumatize a patient. Using the de-identified screening tool can be one of the best and most supportive ways to get the information that you need in terms of that ACE score.
George, this is Mark. I want to go down to the 4th point. We who have ACEs Aware Network of Care planning grants, for those of you from out of state, particularly, the key here is for us to engage with and bring into the fold medical providers who serve Medi-Cal patients. And the challenge that we are seeing in recruiting those medical providers are the challenges that they see in their offices without sufficient staff to conduct the care coordination. So it's really important, in particular, that we have a network of care to make referrals easily. And that's what Hector was talking about with the Kern Connected Community Network and the Unite Us platform that's being used with around 60 service providers. But ultimately, I think that last point around ample training is a key one, and the state is beginning to address that with some of their materials from ACEs Aware, and that's how to get those medical providers set up and confident in implementing the screening, because once they do the screening, there's responsibility that they take on for managing that. And we're seeing from the numbers coming out of the billing that's being done, because they've offered a $29 reimbursement to a medical provider to conduct the screening. And there are limitations on how often that can be done. But bottom line, that $29 only goes so far. But we're seeing about, let's say, 10% of the patients that they're screening have high needs, high ACEs that warrant making referrals. So that's not an insignificant number. And I'm simply kind of putting a marker down for our conversation that we need to collaborate around how do we prepare and recruit these Medi-Cal providers so that they will join, they will use the screening tool, and they will make the referrals that we're asking them to do in order to solve some of the issues that families have that are related to social determinants of health in particular. So that's my comment. Thank you.
Thank you, Mark. And I think, for most grantees, we've actually heard this from Aurora, that the biggest hurdle is getting the primary care providers, getting the teams who are actually working to come to these events, to get educated, to really understand, to dive into the core trainings and the supplemental trainings. That has been a tremendously difficult task, and it's tremendously important, because I think a lot of the hurdles that the providers face can easily be worked through, and that we provide those services here in these events. So one thing, well, there's two things that we have kept in mind moving forward with the providers. One is taking it to them, bringing our information to them in a way that's accessible, because I think when we say you have to come to us, it's just more effort. And so taking our education to the providers has been one successful way of actually having that face-to-face encounter. The other thing is getting administrative support. And I think unless you have administrative support that really pushes the providers, if you're working institutionally, you're going to get much less motivation, much less action towards some of the work that we're doing in the educational processes. I'm thrilled to have Family Healthcare Network here, because Family Healthcare Network has a tremendous amount of administrative support for the providers there. I'm actually going to talk a little bit about their protocol right now. This is prior to the referral process. So for Sophia and for Metaxia, this is part of the protocol that's in place for the screening tool. And jump in there and we can get maybe some of your feedback, Sophia, afterwards. But under the Family Healthcare Network clinical protocol for ACE screening, the following steps are taken to administer a screening tool using evidence-based strategy for implementation. I think this is, again, really great that the administration has taken this and moved this forward to the primary care providers to say, this is how we're going to be doing it. ACEs has a clinical workflow, and they also have an algorithm we're going to hopefully jump into. But this is part of their protocol. Number one, the medical assistant greets and welcomes the caregiver. The medical assistant informs the patient that they will need to fill out several forms prior to the appointment. The packet is provided on a clipboard. The medical assistant provides a general description of each form in the packet, providing context. She informs the caregiver that the primary care provider will review the results with him or her. The patient completes the packet and returns it to the medical assistant. The packet is provided to the primary care provider for review and assessment prior to the appointment. Primary care provider reviews the information, and the medical assistant transcribes it into the EMR. Very straightforward, very understandable, and I think a very clean process. This protocol provides a clear workflow for providers to initiate the screening prior to the primary care provider's assessment, and an opportunity for educational component before an appropriate referral. The referral should take into consideration what referral is necessary to reduce toxic stress and what referral might be necessary to reduce concrete social stressors. This is what the primary care provider should keep in mind as they're assessing this. I'm going to show you what the algorithm looks like. Now, as I mentioned it earlier on, but the algorithm is made up of three parts. The first part is the score. What to do with the score? That's the question that comes up with providers. What do we do with this? What does it mean? Excuse me. The algorithm breaks it into a low risk, intermediate risk, and high risk. If you understand the risk that the patient is at, then you can move forward appropriately with referrals. Low risk is a score of 0 to 3. Intermediate risk is a score of 1 to 3 with associated health conditions. And these are conditions that toxic stress can produce. Excuse me. High risk is a score of 4 or more with or without associated health conditions. So again, with the primary care process, when the primary care provider is looking at the score, they're also looking at any adverse health conditions and moving forward on how to educate and where to refer. And that's really what the algorithm is about. Are they at low risk, intermediate risk, or high risk? And again, if they are at high risk, Family Healthcare Network has a protocol. And I think this is really the most important part, because we're looking at If somebody has a score of 4 or more, we need to educate them on how the score itself translates into adverse conditions because of toxic stress. And again, that's really the key here. And when we're talking about toxic stress, we're not talking about individual traumatic events. We're talking about a prolonged state of toxic stress activation. I'd like to read the second part of Family Healthcare's network's protocol and what to do in this case when you have identified somebody to be at high risk. Do they have 4 or more of the ACE score, and do they have an associated health conditions? So note, the first thing to do, if the ACE screening places patient in the high risk category, an appointment is offered by the provider with a Family Healthcare Network behavioral health provider, or BHP. If the patient accepts, then a MA selects the behavioral health ACE visit type to schedule the appointment with the behavioral health provider. If the patient declines, there is documentation, patient declined behavioral health services. So immediately the primary care provider is connecting with the behavioral health provider. And I think that's really key in most of this. I think another big hurdle that primary care providers have in their mind is that that I don't know what to do. This is a behavioral health issue. Well, Family Healthcare Network really addresses that and says, connect with the behavioral health provider immediately. The second part is a warm handoff with health educator or an appointment made by MA as per the provider. 3, the health educator will complete the prepare form and completes the point care registration. Number 4, the health educator can do a warm handoff to community services. And 5, on an initial behavioral health ACE appointment with a behavioral health provider, there will be a review of the ACE screening tool, and relevant internal or external resources will be offered, dependent upon services needed. Internal resources include scheduling with a navigator and health coach, care coordinator or community health representative, or providing a list of parenting or other classes. Lastly, and external resources may include a referral to Central Valley Regional Center, County Mental Health for psychiatric services, psychological testing, additional resources with the Synchrony of Visalia, or other external behavioral health resources can be offered. If additional case management or solution-focused therapy is needed, the patient will be scheduled a follow-up appointment with a behavioral health provider. So we see here that the primary care provider is supported by the behavioral health team in a very clear-cut fashion. If you're a primary care provider or want to know, excuse me, where to get resources, the first step, and I think one thing that's very important, is to go to ACE is Aware and go to the resources page. I'm showing here their resources page. It's broken down by type, topic, and stage. Clinical resources for adults here and for pediatrics here. And if you click on one of these boxes under resources by type, they have a plethora of resources, ACE screening tools, the APA, how psychologists can help, TED Talks from Dr. Burke Harris, and all the resource safe lines, the National Domestic Violence Hotline, the National Sexual Assault Hotline, National Suicide Prevention Hotline, all these in one place. So if you need to know, or if you want to begin to have an understanding of what resources might be out there, ACE is Aware is a great place to start. I'd like to look at a case study here real quick, and then we're going to dive into our 211 context. Eric is a single 40-year-old man with a history of smoking, and in the last 5 years has developed diabetes. Eric needs help getting medical coverage to pay for his diabetes medication and needs help to quit smoking. Eric went to ARIA Health Community Center to meet with a primary care provider about concerns over his diabetes. An intake specialist provided a de-identified ACE screening tool for Eric to fill out. Once in the exam room with the primary care provider, and after reviewing his intake paperwork, his provider saw that Eric had an ACE score of 6 and at least 2 ACE-associated health conditions. This prompted the primary care provider to ask Eric about how he copes with stress. That was the initial question that came up. How do you cope with stress? Eric responded that he smoked to relieve himself of stress. At this point, the doctor provided Eric with information about toxic stress and how it can change our physiology in the long term, causing a wide range of adverse health conditions as well as behavioral health, negative behavioral actions. He reviewed the stress buster wheel with Eric, and together they chose 3 areas where Eric could improve: sleep, physical activity, and nutrition. Together, they created a treatment plan to make an initial step forward in his overall health. Eric gave consent to the doctor to provide Eric with a referral to a social worker who specializes in health insurance through the Kings County Referral Exchange and the Unitas platform. The social worker was able to help him with appropriate insurance support that would help pay for his diabetes medications. Eric's social worker then referred him to the Salvation Army Food Bank to help with nutritional needs and education around healthy nutrition habits. Eric's social worker made an out-of-network referral to Living Word community programs for substance abuse counseling from the 211 platform to help with the smoking habit. So we really have a coordination of care happening here that is being undertaken, or I should say initiated at the Referral Exchange platform, the Unitas platform. ARIA became his entry point upon getting all these services he needed, and the Unitas platform was the technology that linked him with the social worker. One of the advantages of connecting with Unitas is that Eric does not have to retell his story with each and every provider. It's a one-stop shop. His case travels with him, and each provider is able to communicate with each other to support Eric's health and well-being. As he gets connected to more services, his care team will grow and Eric's diabetes can be managed as he continues his journey to stop smoking. So without ARIA's Community Healthcare Center being on the Unitas platform, Eric wouldn't have been connected to services as quickly, and his health issues could have worsened. If your organization is interested in learning more about the Kings County Referral Exchange program, we're going to be having Lexi and Erica talking about that in just a second. So moving forward and just kind of wrapping up this portion of the talk, the Network of Care Roadmap is an important document. If you have not heard about the Network of Care Roadmap, they talk about milestones for clinicians, and they also talk about milestones for the community. Who here is familiar with the Network of Care Roadmap? Who here, if you can just, let's see, in the reactions comment, if you just raise your hand, or put a hand up if you are familiar with the. Yes, Hector, good. Lexi, Mark, and Rocio. Excellent, yes. So one of the things that's important about the roadmap that I think you should go to, if you have not read the entire thing, is the milestones. What are those aspects in the roadmap that we need to accomplish? Evaluating and improving the referral process is what we want to look at here today. Milestone 5, monitor, evaluate, and improve the referral process. There are several different existing approaches that can be used to guide clinical QI efforts. For example, the Institute of Healthcare Improvement, IHI, has adopted the model for improvement developed by associates in process improvement for quality improvement efforts in the healthcare setting, which describes a plan, do, study, act framework that can be utilized to improve clinical protocols for the trauma-informed network of care referral process. The PDSA framework is based on 3 pillars. We're going to look at those now. So once you have established, once you have connected to a referral process, either through ACEs Aware, through a network of care system that's already in place, how can you improve it? And that's what we want to touch on here. The plan, do, study, act process is one way of doing that. This model for improvement developed by associates in process improvement is a simple yet powerful tool for accelerating improvement. This model is not meant to replace change models that organizations may already be using, but rather to accelerate improvement. The model has been used very successfully by hundreds of healthcare organizations in many countries to improve many different healthcare processes and outcomes. Now, the model has 2 parts. If we look at the top part of the page, 3 fundamental questions which can be addressed in any order: setting goals, establishing measures, and identifying strengths. And then the plan, do, study, act cycle to test changes in real work settings. The PDSA cycle guides the test of a change to determine if the change is an improvement. Now, for those of you that are here, again, this is a lot of information we're going to be throwing at you. We have a resource book that I'm going to put into the chat. This resource directory does list the PDSA cycle. Let me see if I can put that in. And if that doesn't come through on the chat feature, what I'm going to do is I will email that out to all those who are in attendance today. It will have this information of the PDSA. It will have the information that we covered today. Sherry had a question about the slides. The slides will be available after the presentation. We will provide that information to you. So slides and all the resources that we talked about today are available. And we probably will send that email out hopefully today, if not then by Monday. So you'll have all this information. With regard to the PDSA cycle, in terms of setting goals, and this is the last thing I want to go over because goals are so important. The goals should be time specific and measurable. You should also define specific population of patients or other systems that are affected. So when we're looking about change, when we're looking about doing something, improving something, we need to be specific. There is something called SMART goals. The first step in the quality improvement process are setting goals and establishing measures to assess progress toward achievement of these goals. In establishing measures, it's important to identify the data sources needed to track improvement and ensure that the data are readily available in the frequency needed. Examples of effective goals for clinical protocols for referrals in the trauma-informed network of care we'll talk about. The goals and measures identified should be applicable to the circumstances of the provider and the patient served, and SMART. Specific, measurable, achievable, relevant, and time-based. So specific, be as clear as possible. The more narrow your goal, the more you'll understand the steps necessary to achievement. I want to increase referrals by 25%. SMART goals. Measurable. What evidence will prove you're making progress toward your goal? For example, improve the warm handoff process. All patients in need of behavioral health services receive a warm handoff to behavioral health providers. Possible measures, 25% increase in a warm handoff to a behavioral health provider by X date. Possible data sources are the referral tracking system and clinical personnel interviews. So setting these milestones along the way will give you the opportunity to reevaluate and course correct as needed. When you achieve your milestones, remember to reward yourself in small but meaningful ways. So for example, when we reach 10% increase in these referrals, a lunch will be provided to the staff. These incentives go a long way in actually getting traction with the work. A, for achievable. Is the goal achievable? Setting goals you can reasonably accomplish within a certain time frame will help keep you motivated and focused. Using the above example of improving referral rates, you should know the number of people who need to be trained in the referral process, the commitment necessary, and the dates they are expected to be incorporating the referrals. Before you begin working towards goals, decide whether it's something you can achieve now or whether there are additional preliminary steps that you should take to become better prepared. R, for relevant. When setting goals for yourself, consider whether or not they are relevant. Each of your goals should align with your values and larger long-term goals. If a goal doesn't contribute toward your broader objectives, you might rethink it. Ask yourself why the goal is important to you, how achieving it will help you, and how it will contribute toward your long-term goals. Does your staff need training in communication techniques, or should it simply be a process-oriented training? And finally, time-based. What is your goal time frame? An end date can help provide motivation and help you prioritize. For example, if your goal is to have all clinical staff be trained on the referral process, you might give yourself 3 months. If you haven't achieved your goal in that time frame, ask yourself why. The time frame might have been unrealistic. You might have run into unexpected roadblocks, or your goal might have been unachievable. SMART. So improving the referral process, think of SMART goals and make sure that each aspect of this is incorporated. At this point, it is 8 o'clock. The Do Study Act portion of the Plan Do Study Act will be included in the joint resources booklet that we're going to be sending. It's a PDF. And finally, we're going to pass this over to 211. We've got 10 more minutes. We will be ending at 8:10. Make sure you stick around until 8:10, where we will be doing this raffle. The raffle today will, for those of you who have been here before, you may know that we have raffled off prizes in the past. What we're doing now is we are raffling off a contribution to a charity of your choice here in the Central Valley. So I'm going to turn this over to Erica. Erica.
Thank you, George. So good morning, everyone. As I mentioned earlier, my name is Erica Lopez. I am the 211 coordinator at Kings United Way. I'm going to be giving an example on how Eric, George had mentioned him earlier, how he would access resources with 211 Kings County. But before I do, I like to give information on what 211 is and how you can access 211 Kings County. Next slide, please. So what is 211? 211 is a directory of resources you can use to find different resources in the community. In Kings County, you can access 211 5 different ways. All ways to access 211 are available 24/7. Dialing 211 links callers to a call specialist who directs them to basic resources such as food, shelter, employment, healthcare, and more services. Resource information can be given over the phone or texted to caller. If caller agrees to a follow-up, me and my team will then follow up with the caller to ensure they were able to get connected to the agencies they have contacted or they received information for, and also provide any additional resources if needed. Clients can also text their zip code to 898211. And you can also search our database through categories on our 211 Kings County website. But if you're having some issues looking for resources, you can also chat with the live call specialist, which is available 24/7. You can also search for resources through our database by downloading our mobile app called 211 IntelliFull. 211 IntelliFull is available in both English and in Spanish. So in the next slide, I'll be giving a short demonstration on how Eric would be looking for resources on our mobile app. So George mentioned a patient named Eric earlier during our presentation. And as you can see on the right side of the slide, we will be playing a short video demonstration on how Eric will be accessing these resources. So as we know, Eric is a 40-year-old man that has diabetes and needs help quit smoking. After visiting his doctors, he is offered a 211 brochure. So he downloads the mobile app 211 IntelliFull. As you can see on the screen, he searched through Hanford for this example. He was presented with a list of categories. In this case, we know Eric is looking for health insurance as well as resources that can help with his diabetes. So he will click on the health category and scroll down to diabetes subcategory, as well as go down to health insurance. And so when you click onto a main category, it gives you a list of subcategories, which will then give you a list of programs. And right here, we know he needs help to help quit smoking. So in this case, he goes back to the homepage and clicks onto addictions, scrolls to the bottom and clicks on smoking prevention. Here on the screen, you see information on the program, such as description, phone number, website link. You can also share the resource as well as provide feedback to me and my team. And in the last example, a few seconds ago, Eric had went ahead and he was able to favorite the resource and go back to it at a later time when he's ready to connect with those resources. So next slide, please. Just a reminder, 211 Kings County, we do have brochures and posters available in both English and Spanish. So here displayed on the screen, we have the posters available. If you're interested in having these in your office or your clinics, passing the brochures out to your patients, my contact information is listed in the chat box. I do encourage you to reach out, and I'd be more than happy to drop some posters or brochures off. At this time, I would like to turn it over to Lexi to provide some information on the referral exchange. Thank you.
Thank you, Erica. Again, my name is Lexi Terrell. I'm the Community Engagement Manager with Kings United Way. 2-in-1 will always remain an essential resource for our community, but now we need more community connections and a referral management system. George talked to you a little bit about the Kings County Referral Exchange and introduced you to Eric. So I'm going to dive a little bit deeper. The RE will supplement the efforts of 2-in-1 by becoming a database for providers that enables you to send referrals to other organizations on the platform for your client to get connected to appropriate resources that reduce toxic stress and address any other health needs they have. Built-in screeners like the ACEs screener and the ability to download reports make the RE a versatile tool to support our organizations and our community. Now let's take a look at what a client profile will look like on the Unitas platform. Next slide, please. So George introduced you to Eric and talked about his entry into the RE after he found information on 2-in-1 from for ARIA Community Health Center. He got connected to a social worker, Hanford Salvation Army, and substance use counseling. Plus, the ACEs screening the provider conducted will stay a part of his client profile. Without having programs listed on 2-in-1 and the referral exchange, Eric and others like him would have to call organization after organization to try and find some help. All services are geotagged to be able to get the client to resources that are close to them and shouldn't require special transportation. Once the referral is sent out, that organization gets an email notification that a referral is waiting. Then they can go in and accept the referral and get the clients to services much faster than having to call all the service options. The client can also choose to get email or text notifications when a referral is accepted so no one falls through the crack of care and everyone on his care team stays up to date. Next slide, please. To get Eric and other community members to the services they need, we need all organizations that serve Kings County to be on the Unitas platform. The connections made on the platform will create the Kings County Referral Exchange, but also extend to the Unite California network for the community members that move beyond our care. Here are some upcoming sessions for you to learn more about the Unitas technology platform. Information sessions cover how it can be used and how your organization can join. If these dates and times don't work for you, please reach out to myself or Kendra DeBajian from Unitas to schedule a session that works best for you and your organization. I'll provide the links to the 2-in-1 website and the information for the referral exchange, as well as Erica and I's emails. Thank you so much. Back to you, George.
Thank you, Lexi. Any final questions? Any final thoughts? I would love to hear any comments about what worked today, what you found interesting, one thought that sticks out in your mind. Something interesting, something that you may not have thought about before, or any questions that may have come up.
I like to hear, George. I think one of the things that I found interesting today was just the workflow that one of your providers is kind of utilizing to support your in-clinic recruitment. You know, as we're working to support and document some of those, it would be great to kind of, if we can share that, you know, if they're willing to share that with us in Kern County so that we can share that with our providers, and vice versa, as things come up within our pilot, you know, we're more than happy to share that with Kings County and other folks there to create some learning space and learning opportunities for that. So.
Excellent. Yes, I'll make a note of that and make sure that we get that workflow over to you. I think, you know, ACEs Aware does have a workflow, and it can be utilized, but different providers have individualized their workflows, and I think it's good to see what they have, how they've utilized it and made it work in their organization, their institution. Any other final comments? All right, I have one last point of information. We have a survey for this presentation. I'm going to pop that in the chat. If you click on this link while you're here, it's in the chat right now. If you click on the link and give us your feedback on our presentation today, our provider engagement peer-to-peer session, coffee and engagement, coffee and connections. We would love your feedback. It just takes about 5 minutes. It's a quick survey. Click on the link now so that you have the window open. And what we're going to be doing is a raffle. At this point, for those of you that are here, we will have one raffle winner who will be able to make a contribution to a local charity. I'm going to stop sharing my screen and turn this over to Cameron. And let's see who our winner is. All right, Hector, you are a winner. Congratulations.
Great, thank you.
You bet. I will be sending you an email with the options for charities of your choice, and we will make a contribution in your name.
Perfect, thank you so much.
And at this point, we're 1 minute over our scheduled exiting time. I would like to thank all of you for joining us today and have you be a part of this ongoing educational experience. Thank you, Liz. Appreciate seeing you. I hope we gave you some information that you can take with you back in Ohio. Yes, good, excellent. And keep coming back. On Monday is our Network of Care, this coming Monday. Keep an eye out for our Network of Care meeting. You'll probably be receiving a email about that. For all of you that are here, I do have your email addresses as you did register from Zoom, so you will be put on our Network of Care mailing list. Network of Care is a great meeting, 2 to 3:30. You have a lot of important information and some real good traction in terms of how the network is moving forward here in the Central Valley. So on that note, I would like to wish all of you a wonderful weekend and let you know that we are complete today. Have a great rest of your day, great weekend. And again, we appreciate you coming. Thank you very much.